Thank you very much, Jens. Ladies and gentlemen, Jens, our friendship and collaboration goes now back 30 years, unbelievable. Because of that collaboration, lots of this work was possible, and I thank you for that very much, because lots of the things which I present here were developed together. Well, I'm coming from Bochum, which is in the Middle West, western border to Germany. In fact, yes, it was one of the first trauma centers built just for trauma within the workmanship compensation system. Here you see our first hospital in 1890, and the development of new techniques was always one of the first things which come to mind in trauma system. They were brought to the hospital. As an example, radiology department started in 1896. You may remember that X-ray was developed 1895. The hospital became part of the university only in 1976, and since that time we're in the academic work very busy and involved. Nevertheless, pelvic studies started and were published already in the 20s with results of more than 1,000 pelvic fractures treated at Berkmansheil. And to show you what we do in the region of the hospital, there was a market analysis done a couple of years ago, and it shows that Berkmansheil covers around 50% of the pelvic fractures which were operatively treated, and in the same region you have 13 larger trauma centers. So we take care of quite a bit of that. Well, Jens, you asked me to speak about less invasive to most invasive sacral fracture stabilizations. And we have quite a few various techniques to do that. But in this talk, I want to concentrate on SI screws versus lumbopelvic fixation techniques. And if we address these, then we have to know what are we dealing with. We heard about the various theoretical fracture types, but in reality, the situation is often different. And you see here some examples of major trauma with destruction of the pelvis here or here after gunshot injury, severe soft tissue problems, lumbopelvic dissociation, closed soft tissue problems. But on the other hand, we have spinopelvic instabilities due to insufficiency fractures, pathologic fractures, as you can see here, infection in spinal cord injury with pseudarthrosis, and you see the instability here, or even secondary failure. And this is acute secondary failure, but on the lower hand, you see also deformity and failure after SI screw fixation 6 years post-trauma. And that's an unstable situation which we also have to address. Or you see nowadays, and everybody of us has to deal with that, chronic insufficiency fractures, and the question is, what do we do with that? Well, I don't want to go through the classification system, but I just want to mention again, this is one issue to understand what we talk about. On the other hand, it doesn't really help us too much in make the decision about which stabilization technique should we really use. So in my eyes, we have on the one hand classifications with fracture lines, but in order to decide what we really want to do, we have to include the fracture reduction, because if it's not good, then the stability is impaired. We need to know what is going on with the soft tissue. We need to know what the bone mineral density is like, because the implant bone interface is of utmost importance for our post-operative mobilization. And of course, we need to know what the neurostatus is, because that has an impact as well. All of these things help us to make a choice which technique and sequence of sacral and pelvic lumbar stabilization we will perform. The other thing which you have to keep in mind is what degree of instability do you really have? And in my eyes, we have a sequence of more or less 3 groups of injuries and instabilities at the lumbosacral junction. First of all, there's the sole sacral fracture or pelvic ring fracture with some L5S1 fracture facet involvement. That is unstable, no question. However, if you have a sole lumbopelvic fracture dislocation or dissociation, that is a more directional instability, which may have to be addressed in a different way. And the most problematic unstable situation in my eyes is the situation with an highly unstable pelvic ring injury with an L5-S1 lumbosacral dissociation, because there is an increase in multidirectional instability. We have to adjust this stabilization technique. And again, we heard already, we have to consider the type of patients which we have. We have to think in the categories of acute trauma in young patients versus old patients, and also chronic insufficiency fractures without any trauma, and of course the soft tissue. And in order to get a kind of sequence and some better overview, I like to address these different issues and compare then the fracture, the stabilization technique. In a table like this, I try to explain that better to you. First, let's look at the fracture reduction. If we have a very good anatomic reduction, then an SI screw is definitely easier to do, can be of more usage and is more stable as if there is a comminuted fracture. And the way around lumbopelvic fixation is even more necessary, the higher unstable and the worse the reduction for whatever reason there is. So the other thing is with the bone mineral density, if you have a very weak implant bone interface, then an SI screw is probably not the choice which you should think of, but in a strong, good bone mineral density situation, this may be a very good option. And vice versa, lumbar pelvic fixation should be considered even more if you have a very bad bone mineral density. On the other hand, in the soft tissue situation, if you have a worse soft tissue situation, it's vice versa again. If you have severe contused open soft tissues, because of risks of infection or any other wound breakage risks, you may not really want to go ahead with lumbopelvic fixation. On the other hand, if you have an infection, it's of utmost necessity that you need maximum stability. And at the end, near status and other comorbidities. If you have a paraplegic patient, then you may want to use a more stable fixation, like a lumbopelvic fixation, to avoid at the lumbosacral junction a Charcot spine. On the other hand, if you have a patient who is bedridden, you may not need that, and you may get more pressure sores and problems in the end. So all of these things show you that you have to differentiate really your patient and your situation, and then make a choice. So there is not a clear-cut decision just looking at the fracture lines and then come to the type of fixation. So let me talk about SI screw fixation first. We can use the S1 or the S2 level for sacroiliac screws. Of course, S1 is better to do, better to perform, because S1 is just a larger bone, but it depends whether you have a dysmorphic or a normal anatomic sacrum. And there are different types of screw fixations: unilateral, bilateral, transsacral, all the way through. You can do interdigitating screws with, which result in better stability, and that's a completely different issue. But we go through the wet lab later to show you how to do it. But I have here a sequence, and you see here, for example, the anterior border of the sacrum in the lateral view. You see here the alignment of the ischial notch, which has to be aligned to know exactly where your landmarks are for screw placement. You see here the anterior border of it. You see here the sacral canal, which you have to know where it is if you want to avoid the S1 route, which goes and crosses the lower part of the S1 vertebral body. And then from a lateral side, I prefer to directly adjust the guide wire for the cannulated SI screw and adjust that in a perfect bullseye position. And here you see that, and then I know that I avoid the L5 nerve root, which goes just here up that slope of the sacral ala, and here's the sacral canal, which goes down here. So I know exactly where the nerves are. At least I think I know. And then I turn around and take the inlet and outlet views. The inlet view, you try to adjust the S1 anterior border and S2 anterior border and align that. And with that, I know that my K-wire is perfectly in the S1 vertebral body. And here you see the border again. And then I change again the position with the C-arm. Here, the S1 root foramen, you can see the anterior border of the parasymphyseal bone, and you adjust again the position of the outlet view so that the anterior border of and the upper border of the symphysis is approximately at the level of the foramen of S1. And then I know again that my K-wire and guide wire is in between the border here where the L5 nerve root is and here where the S1 nerve root is, and should be in a safe position. And then I can drive the K-wire, guide wire further on and check it again in the two positions. I overdrill it. In osteoporotic bone, I don't overdrill the complete sacrum, but just the lateral parts of the tabula externa, interna of the ilium, and the tabula externa of the sacral ala, and that's it. And then I drive the screw in, checking, of course, whether the K-wire and guide wire is pushed forward. You have to check for that. And then I do a rollover view, and I bring in a fully threaded screw, especially in the osteoporotic bone, and look at the washer, and you can exactly see how it's getting closer to the border, and that is where I need to stop. And then I get my final views, and that's it. However, if we have such a nice technique, why do I need something else? This technique is nice, but it doesn't work all the time, especially if you have unstable situations. And that drove us that already in 1994, a couple of groups came up to do an additional horizontal stabilization to the vertical stabilization as an adjunct to the horizontal SI screw fixation. And that worked out pretty well. We were able in young patients to mobilize them and fully weight bear them right away. But in the elder patients or in tumors or osteomyelitis, we saw that the short screws started to lose and that we have a whiplash effect, windshield wiper effect. And that actually came up when Jens and I worked at Harborview, and the idea came up to use longer screws. So we did analyses how longer screws can be used in the ilium, looked at different cortical narrow areas, and then came up with the screws of 7 to 8 millimeter diameter and up to 90 to 140 millimeter as a minimum size for a good anchorage. These screws can be put in without navigation system, but we will hear in the next lecture, I think, how additional techniques can help us with that. The main views which we use are lateral obturator outlet, obturator inlet view, and this will be shown in the wet lab as well. Now, lots of biomechanical studies have shown that various stabilization techniques did not really result in significant changes in stability. However, in our cyclic loading study with up to 10,000 cycles, there was a highly significant better stability with the lumbopelvic fixation, which seemed to confirm also our initial clinical results. And the reason is that your center of rotation, inflection, extension at the promontorium here is bridged over with long lever arms with the long screws. So your lumbopelvic fixation is working like a tension band on the dorsal side and counterforces the flexion forces through mobility. Well, the technique, and we can discuss that later, just to give you an overview. If you have an unstable pelvic ring combined with a lumbar-pelvic fixation, you need to stabilize your anterior pelvic ring first, because you have a highly stable posterior osteosynthesis, and if you have not a perfect reduction done from posterior for the whole pelvic ring, you will never be able to reduce your anterior pelvic ring anymore. So you have to finish first anteriorly, and that gives you also a fixed rotational point in the pelvic ring, and then you can close later the pelvic ring from posteriorly. And that all can be done again on the C-arm control. Well, at the beginning, we did a standard trajectory, used a standard trajectory for the iliac screws from the PSIS, pointing and going to the AIIS, but that resulted in some clinical situations in soft tissue problems because of prominent screws. Although we recommended to really recess these screws and take off some bone chips at the PSIS, especially in elderly people with bad soft tissue situations, we saw that. And Jens and one of our fellows, Dr. Glinsky, they worked on the modified iliac screw, and you see here the trajectory and the entrance is just a little medial to the PSIS. And that technique also resulted in the same good positioning of the iliac screws and in the same stability of these screws biomechanically. Well, reduction maneuvers. There are a couple of reduction maneuvers. The thing is, though, and I like to point that out again also for discussion, in the geriatric population, if we have a severe kyphotic at the insufficiency fracture, it may be very hard to reduce these fractures, because if you use a bone impactor there or a COP elevator or anything, you may not really reduce your fracture, but impair and impact your osteoporotic bone. So the more difficult that situation is, the more I tend to do an in situ fixation, but definitely do a sacral laminectomy and a foraminotomy to free the neural structures and then stabilize it. Otherwise, of course, there are chances to use bone impactors. There are interesting techniques and chances to use a drill and a shank pin to really guide up your segments of the sacrum for reduction. If you know the anatomy, it's quite a safe technique, but you need to know exactly where you are. And I want to go now through a couple of indications when we use that technique. Of course, in regular trauma. This is one thing. You can use it in lumbopelvic fracture dissociation in young people with good bone, and we could show that the stability is there, but the question is, how do we do it in the secondary displacements? And there again, you treat that like a lumbopelvic fracture dissociation. In more chronic situations, you have to do a prone, supine, and prone approach again, where you have to take off all your fibrous tissue and reduce. And you see here that this is nicely possible and results in a stable situation where you can fully weight bear the patients right away. The same is true for tumors and highly unstable situations like in this completely destroyed sacrum. And you see the patient down there within 1 week of the operation. So it is a very stable situation and a 1-year post-op. More interesting nowadays are the sacral insufficiency fractures. If you have the bad situation that you have the displacement, if you have to do a lumbopelvic fixation technique. However, to avoid that, I recommend to use the SI screw in the non-displaced fractures to avoid that secondary problems. So that would be the differentiation, which technique to be used. Other things, spondylodiscitis or chronic Charcot joints can be stabilized very nicely with the lumbopelvic fixation technique. The same here. We use just one rod technique on each side. To discuss is here the point to use 4. This is the follow-up, 3-year follow-up. Complications have to be kept in mind. Soft tissue problems are more of a problem in the lumbopelvic fixation. Loosening, neural tissue involvement, and complications are an issue with the SI screws. The do's and don'ts. Don't do a distraction osteosynthesis when you do the vertical stabilization in the fractures. Use at least 90 millimeter screws, not tapered screws, because you need a good fixation in the anterior iliac canal. And with that, you should have a stable situation. So this was a quick run through. I hope this gives you plenty ideas for discussion, and I'm looking forward to that, and thank you for your attention.
That was incredible. I congratulate you on your commanding view of this topic and your eminent contributions. Literally, this is so impressive. So tell us again a little bit about SI joints and SI joint screw fixations. Who should do those? Is this something where we have to call the trauma surgeons in, or should we as spine surgeons have this skill set in our hands?
Well, that's a political question. The best would be if you have a trauma spine surgeon who knows the pelvic and the spine in this area. I would say I'm a trauma surgeon and cover all these areas. You have to deal here with the complete lumbopelvic junction. If you have a trauma surgeon who doesn't understand or doesn't treat the lumbopelvic junction, then this is not good for the patient, and vice versa. Both techniques are learnable, and spine surgeons should take care of that, as trauma surgeons should be able. But definitely an intervention analysis, radiologists, just with injection techniques, is the largest problem which we face, especially in the insufficiency fractures.
So, Dr. Daly, recently a company has brought out far more SI kind of fixation options for pain management, and they've now morphed into more aggressive forms of trauma reduction, as we'll see shortly, and we thank them for their support. Do you find comfortable doing this in your skill set now at the University of Utah? And by the way, congratulations on the Pac-12 title, beating SC last night. But is this something that you feel comfortable doing now? Who should do these SI screws at the University of Utah?
You know, that's a good question, Jens, because unfortunately, I don't really understand the SI joint that well to know who to actually put them in. And that's the problem, is identifying the patients who have SI joint pain and trying to figure out who would benefit from this. I personally don't do these, and they are actually done out in the community. The ones that we do are basically S2AI screws that we use at the end of long deformities or for trauma or something like that. And those patients tend to do pretty well, but it's not something that I do primarily.
I'll ask Dr. Cecino to take a step up to the podium because she has some very cool new things. We always learn from our fellows as well, and she's from Johns Hopkins, and her chief there, Dr. Witham, is here with us also. And so learning from our fellows is one of the great privileges of an educator. And in terms of visualization, they have just opened our eyes to something completely new. And I'll ask Dr. Witham to also comment, and thank you for coming out. Dr. Schildhauer, as Amanda's getting ready, how hard is it to put lumbopelvic fixation around an SI screw? Let's say we have a situation where we put an SI screw in, it's nicely positioned. How easy or hard is it to get a kind of lumbopelvic fixation around that?
If you have a normal anatomy, the SI screw is more cranial because the ilium screw is at the level of S2. So therefore, you never have that problem. Of course, if you have a dysmorph sacrum, there may be a problem in that if you use then an S2 screw, it may be a problem with the ilium screw. But typically, it's no problem.
Dr. Choma, any comments? You're obviously an experienced trauma surgeon and spine surgeon, and you've taught this many times, so give us your thoughts.
Actually, I just wanted to ask Dr. Schildhauer a question. So you went through really well the iliosacral screw process, but that's in the case of anatomically reduced SI joint. Some of our traumas, it seems impossible for us to get anatomic reduction. Are there still roles for iliosacral screws, or is that a no-go if you can't get anatomic reduction?
Well, that's a very important point, and that is you see always these nice reduced and more or less anatomic situations where you put in the SI screws. If you cannot reduce your fracture or you have a crush injury or impaction, you then have only the option to bridging osteosynthesis dorsally. And in that situation, we would definitely recommend a lumbosacral stabilization, a triangular osteosynthesis, we call it. Triangle because in these pictures you might have seen, you have the vertical stabilization combined with the horizontal stabilization. Again, there, if you do it at this concept, we would have an SI screw. If you cannot get that in, we would go to a bilateral lumbopelvic fixation with a cross connector. Originally, like 15, 20 years ago, we used a plate. Because of soft tissue reasons, we don't do that anymore. So we use then very typically a bilateral lumbopelvic fixation with one or two cross connectors, depending on how many levels in the lumbar spine you go cranially.